So thank you very much, Dr. Kielar, again for this informative lecture. And now we're starting questions. We have few questions, and I remind all of you to send questions directly to me. So the first question was from our friend, Dr. Kidar Jim Baker from Arkansas. Kidar?
Yes, Khaled.
Good afternoon.
Good afternoon.
Okay, go ahead.
So Ania, those were great cases. I've been involved with the LI-RADS for a few years, but I always have a problem with the new table where we say that to differentiate between LR4 and LR5, if there is washout, you change it to LR5, and you showed an example of that. Number one, how many times do you actually see a lesion which is arterially enhancing between 10 and 19 millimeters, but with no washout, with just a capsule?
I have never seen that.
I'm sorry?
I have never personally seen that, but
Exactly.
I'd love to hear from maybe if Victoria's on the line, if she's seen that, because she's got a lot of experience.
I think what's nice about these questions is we have also a panel of colleagues. So there is Victoria, there is also Claude. So anyone is allowed. Please go ahead.
It's true that such cases are very uncommon, but they're not inconceivable, and we have seen them. So yes, it's true that they're not common, but they do happen.
So how would that actually look like, Victoria? How would a lesion which is arterially enhancing, but there is no washout, how would you actually even see a capsule?
The capsule looks like a little ring of enhancement. Like you can recreate it in PowerPoint or in Photoshop. Just take a gray square and put a little circle of brightness in the center. That's what it looks like. So there's just basically you see that the inside the circle and outside the circle are the same color, but the circle is brighter. Again, it's uncommon, but it does happen.
I wonder if you'd be at risk for mock effect, where you think that the center is actually washed out because you see the bright circle next to it.
Right. So that's one of the pitfalls, that your eye perceives washout when it's actually not there. But it can happen.
Okay.
Great.
Thank you.
I think our point is like you still see the hyper enhancement because it's not really washing out, and the enhancing capsule will not be able to really distinguish from the central still hyper enhancing observation.
This is Michelle speaking. So I agree with Victoria. I've seen it a few times, and the way I like to describe it when I talk to my residents and fellows is that the central part is iso enhancing to what the background liver parenchyma is on that portal venous and delayed phase, but that capsule around is hyper enhancing. And I agree, sometimes it's almost like a mock effect where you think that it's washing out, but it's actually the same intensity or density, whether CT or MR, as the background parenchyma at that phase of imaging. So it's still enhancing, but it's iso enhancing and not hypo enhancing.
This is a case from an outside institution. I think this case was maybe from about 2015. I don't remember exactly. We see that there's, in the early arterial phase, we see there's a mass that's hyper enhancing. Notice that the mass looks a little bit larger in the late arterial phase compared to the early arterial phase, and some of that is probably related to corona enhancement and summation. In the portal venous phase, the center part of the mass has de-enhanced, and on the delayed phase again, it has de-enhanced. Now, this particular lesion was interpreted on the outside as having arterial phase hyperenhancement and washout, and it was called the LI-RADS 5. It was appropriate to call this a LI-RADS 5, but it's not appropriate to say there's washout. There's not washout. If you look carefully at the mass is perfectly iso-intense to the background liver. So according to the LI-RADS definition of washout, this is not washout. Now, just to prove it, I did something that is normally a no-no, but I did it for teaching purposes. So here again is the mass, and you can sort of see that there's this capsule. But what I did is, using Photoshop, I eliminated the capsule. And if you eliminate the capsule electronically, notice that the lesion has now disappeared. You would not call this washout. This would be called fade to isointensity. I believe my colleague Mustafa Bashir published a paper on this. The visual perception of washout due to the presence of a capsule when there is no washout. So this is what it looks like. Now this lesion is bigger than 10 to 19 millimeters, okay? This lesion is 23 or 22 millimeters, but you can imagine the same thing might happen with a small lesion, and I have examples like that, although I don't have them to show you right this instant. So I hope this answers the question that you can in fact have the mock effect or the visual perception of washout due to the presence of capsule appearance when in fact there is no washout. Now the other interesting thing I'll mention is that if you look at the radiology literature and look at scientific papers that have described washout, sometimes the papers show examples exactly like this. So the papers have shown examples of washout. These are published papers. When there is no washout, there's simply the visual perception of washout due to the mock effect.
Claude, that's indeed a great example. That example was needed to demonstrate these findings and to clarify the definition and everything. So I think that is very appreciated from all of us. Thank you very much for.
Yeah, if you look carefully, you will see this. I agree with Victoria. It's not incredibly common, but it happens more than you think. It's just that typically we see this and we call it washout with capsule. But if you look carefully, as Michal was saying, at the center of the lesion, you'll notice that the lesion is iso-enhancing to the background liver, and it's just a visual optical illusion.
And this is exactly why I love being part of LI-RADS, because the audience member are even more knowledgeable than the speaker, and it's so great to have this. So thank you.
It is so nice. I think that we are actually all enjoying the exchange of knowledge and learning, and it is a learning process. So our second question is from Dr. Canella from Italy. I think Palermo. Buonasera, Dr. Canella.
Buonasera. Thank you very much for the interesting cases. I have a question focusing on the LIRADS non-categorizable lesion. So in my practice, most often we have imaging artifacts due to motion in the arterial phase. So my question is, if we have a observation that is larger than 10 millimeter, and that's washout, but the arterial phase is not adequate, how should we call? How do you call in your practice? You will call LIRADS non-categorizable, or LIRADS for and remark that the arterial phase is not adequate?
Well, this would be actually a good question to see what different people do. But I mean, if the arterial phase is really, that's one of the key phases, and if I can't evaluate it, then I definitely need to put that caveat in my report, and I probably would go and recommend that they have a CT to characterize it better. But the alternative is that they discuss it, you know, if it's washing out, has a capsule, or it has other features, whatever, you'd end up with LR4 at best, right? So they could be discussed at multidisciplinary case conference, and the surgeons could decide to do a biopsy, or depending on the pretest probability of the patient, do something about it. What do other people do?
Yeah, hey, Ania, this is Claude. So I agree with your approach. Just wanted to clarify the LI-RADS instructions for this. So what LI-RADS says is that if one image, like the arterial phase, is missing completely or just uninterpretable due to motion, you don't necessarily call it a LI-RADS non-categorizable. To apply LI-RADS non-categorizable, you have to be in a situation where you're literally not sure whether the observation is more likely to be malignant or benign. So for example, if I see something that is hypo-enhancing on the delayed images, and it has, let's say, restricted diffusion, in my mind, that's probably either a LI-RADS 4 or a LI-RADS 5. Now, if there's no arterial phase, I can't call it a LI-RADS 5, but I can still say it's at least a LI-RADS 4. So I wouldn't call that LI-RADS non-categorizable. I would say this lesion is a LI-RADS 4 or worse, but I can't fully categorize it because of the missing arterial phase. So I would recommend the patient come back for arterial phase imaging, either with CT or something else. But I wouldn't call it LI-RADS non-categorizable, because I can say something about the lesion. I can say this lesion is quite worrisome. It's at least a LI-RADS 4. Does that make sense?
Yeah, that's what I would do.
Now, if literally I couldn't tell, like I don't even know whether this thing is a LI-RADS, you know, if I really just can't tell whether this thing is an artifact, a benign artifact, or a true lesion, then I'd call it LI-RADS non-categorizable.
I think that's perfect. I think that's what most of us do, and it's very reasonable approach.
Well, it's what LI-RADS instructs, but it's possible we don't make that clear enough in LI-RADS that that's what we should do. So it's interesting to get this feedback that we have not made that clear in our LI-RADS core documents or our manual. So we need to make it more clear. And also, if there's anyone in the audience who thinks that's not the right approach, we'd be interested in hearing from you, and we will be interested in considering your recommendations, because maybe our approach is not the right approach, and maybe there's a better approach, but that's the current LI-RADS approach.
I mean, in this particular case, with the arterial phase being no good, it does make it a little bit tricky because you don't really know where you're supposed to start. I agree with you that it's not good. But if I was missing portal venous or something else, then I would really have no trouble because you'd have still the delayed and so on. So it's just, I hate when the arterial phase doesn't work out because it really does put you in a quandary.
Yeah, that's a good point.
So it's like a comment from a dear friend in Egypt, Dr. Muhammad Eid. He's saying, would have liked the example of post transarterial radioembolization or SBRT. The response assessment is sometimes tricky in these cases, but I think Mohammed, we're getting still Dr. Mindrata Lala lecture on May 15th, so it's rescheduled, and we're gonna hear about all of that stuff. And so exciting enough, we have also an interventional radiologist joining us on May 18th, and May 19th is going to talk about a lot of locoregional therapy and interventional procedures to the liver, including transarterial radioembolization. He's going to have session about all locoregional therapies, and he's going to dedicate another session, separate session about transarterial radioembolization because that's his area of interest. That's Dr. Armin Marvash from MD Anderson. Another question here from Amal Al-Asmar. Is this a question? No, she's just thanking you, Ania, for this great, informative, excellent presentation. Thanks, Dr. Khaled, for your whatever. Anyway, Rajesh from, and he's actually a very frequent attendee of our series. So, Raj, you have a question?
Yes, Dr. Khaled, I can hear you. Can you hear me?
Yes, sir.
Yes.
Go ahead.
Yeah. So let's say we started with Dr. Ania Kielar. Thank you very much for the excellent cases you showed. So let's say we started with an MRI for a suspected cirrhotic patient, and the patient is claustrophobic, and we end up with an incomplete examination, and we completed in and out and DWI, and take the patient out and do a CT, triple phase CT. So can we use the DWI and fat signal drop as ancillary features and the arterial washout from the CT to combine and get a LIRADS category?
So, in other words, can you use two different examinations and combine the features to come up with a LIRADS category, right?
Yes,
Victoria?
yes, Dr. Elsayes.
Yeah. Okay. Go ahead, Ania.
Well, I mean, my understanding is that if you are missing that series and you supplement it with a different one, then you should be, as long as the timing is reasonably soon, you should be able to. But Victoria, can you just make sure that that's right? We shouldn't be combining stuff like 3 months apart.
It's a conversation which we have been having in terms of how to integrate two different modalities. With caution, it can be done, but we did not come up with a reasonable or definite time period beyond which you shouldn't. The discussion was up to 3 months, but this is just, we have no data to, to say that within 3 months you can combine the features. With caution, a lot of caution, you can, but again, we don't have hard rules for that because data is missing. Claude, please correct me if I'm wrong.
No. It's a brilliant, Raj, it's a brilliant question. We have been debating this internally within LI-RADS for 5 or 6 years. All of us think that logically it makes sense that you could combine features from different modalities, but we don't yet have the scientific evidence to support us. So I think Victoria's response is perfect. I think you can use your judgment. If you are going to combine features, though, please make it very clear in your report that you're saying that your opinion, this is a LI-RADS 5 because you're combining, what the feature from modality X with the feature from modality Y. Make it very clear in your report that that's what you're doing.
And guys, appreciate muting yourself. Please. Appreciate muting.
And Raj,
Thank you.
If you start to do
Claude, I would ask you to repeat this again because there was noise. So I would ask you to repeat the same thing again. Quick, please.
Okay, quick. So this is a very controversial issue. I agree with Victoria that, Raj, you can do this in your own practice with great caution. Please make it very clear in your report that that's what you've done, that you've combined imaging features across different modalities. If you do this, please do consider doing research on this and writing a paper on this. I don't know whether you'll have enough cases. Maybe you can combine with some of your colleagues, but it would be a very interesting paper to show what is the performance of LI-RADS when features are combined across modalities. If you're interested in pursuing this as a research project, please reach out to Victoria and to me, as well as to the research group headed by Mustafa Bashir and Matt McInnes. It'd be a very interesting research project to entertain. It will be difficult to do, but it would be very interesting.
Yeah, that's a great research question. So Raj is.
Thank you all for the response.
Raj, you're from Bangalore in India, right?
Yes, Dr. Elsayes.
Okay, thanks for being frequent attendee of this webinar, and we'll look forward to seeing you again. We have a few more questions. I have question from, she said, I have a question about infiltrative lesions, but she didn't mention the question. Thana Rabia.
Assalamu alaikum. Just I have some concerns about infiltrative lesions when they are accompanied with tumor in vein or not. About the measurement of infiltrative lesions when they are not non-measurable. Will it affect the LI-RADS?
So I think Thana is saying that the infiltrative lesion can be quite commonly ill-defined and non-measurable. Would this affect LI-RADS category?
I mean, if you see tumor in vein, you call it tumor in vein, and the size of the actual lesion will not be as important because it's already tumor in vein. But
when it is not associated with tumor in vein.
Yeah, so you do your very best to give it a size because, it's really, is it less than 10 millimeters or greater? That's important. And after that, I mean, it becomes hard. Does anybody have any tips and tricks? Because
yeah, hey, Ania, this is Claude. This is the issue of quote-unquote infiltrative HCC has been something that we've been debating within LI-RADS since at least 2013. So we've been discussing this now for at least 7 years. It's a very tricky topic. There's not a lot of literature on it. And most of the literature that has validated, the combination of arterial phase hyperenhancement and washout has not been done in infiltrative lesions, but rather has been done in nodular lesions, in particular those that are detected on surveillance ultrasound. This is a very, very difficult topic. What the compromise solution that we came up with in LI-RADS is that if you see an observation that in your judgment is an infiltrative heterogeneous mass. If that mass has arterial phase hyperenhancement and washout, then you call it a LI-RADS 5, assuming, of course, that it's bigger than 10 millimeters. But it would be very difficult to imagine something smaller than 10 millimeters that you would describe as infiltrative. So almost by definition, infiltrative is bigger than 10 millimeters. So if it has arterial phase hyperenhancement and washout, you call it a LI-RADS 5. If it doesn't have arterial phase hyperenhancement, or it doesn't have washout, or you're not sure that it has both, but you're sure there's an infiltrative process, then you call it a LI-RADS M. If the LI-RAD, and then you would say this is LI-RADS M, probably due to HCC, because that's the most likely etiology. But you're not sure, so you wouldn't say definite HCC, you'd say LI-RADS M, probably or possibly due to HCC. I hope that answered your question. If it didn't, please follow up and we can try to clarify it.
Yes, it did. But you know, in Egypt, I see many cases of infiltrative lesions where they are involving 2 or more segments of a loop. And in such cases, I cannot judge if it is infiltrative or multicentric HCC. Would it affect the outcome of the lesion?
Oh, you're saying that you're not sure if it's multifocal.
This is the third one. When it is extensive, involving more than 2 segments of a loop. Sometimes I am not sure whether it is infiltrative lesion or multicentric, but I cannot see a capsule or delayed capsular enhancement. Just enhancement, early arterial enhancement and washout.
So can I add something, Claude? And
yes,
I just want just something logic. If you, in this case scenario that you're talking about is definitely LR5 because you're talking about multicentric or infiltrative, and you're describing enhancement, arterial phase hyperenhancement and washout. That means that the lesion or the observation is big enough to be characterized as LR5. So this will be definitely see, right? But you're
I think Khaled, she's saying,
go ahead.
I think she's
yeah.
I think she was saying she doesn't see definite washout. She just sees heterogeneous arterial phase hyperenhancement, but no definite washout. Is that correct? Is that what you were Is that what you were describing?
No, I see the washout, but mostly in CT, not on MRI.
Okay, if you see arterial phase hyperenhancement and washout, you can call it a LI-RADS 5. Now, maybe you don't know whether it's 1 lesion or 5 lesions or 100 lesions. So then you can just simply say that there's an extensive region of arterial phase hyperenhancement and washout involving segments X, Y, and Z, measuring at least, X centimeters, let's say measuring at least 8 centimeters. And this definitely represents either a diffuse or multifocal HCC. And then, I would recommend multidisciplinary conference, and you can discuss with the clinicians exactly what you see so that the most appropriate management can be considered. And sometimes you don't know whether it's multifocal HCC or 1 diffuse cancer, and even on pathology it may not be easy to differentiate between 1 cancer versus multiple, a confluence of multiple individual lesions. I don't think that distinction is clinically that relevant. The most important thing to say is that there's a diffuse malignant process measuring at least this many centimeters and involving the following segments. That's how I would approach it, but I'm curious to see how other people on the phone call would approach it. Ania, how would you describe something like this?
Probably not as well, but yes, I would say that I'm not sure if it's multifocal or 1, but I would try to give a general measurement, say what lesion segments are involved, and our patients usually come a little bit earlier than that, but they do happen like this, and you just have to do the best you can with what sequences you have available.
Great.
But it's a very good question. It's a very good question, and this is another topic that, you know, this is a topic we've been discussing internally within LI-RADS for quite some time. So if, forgive me, I didn't catch your name, but if you would feel comfortable, please send an email to Professor Cherniak and to me. Khaled, Professor Elsayes can give you our email. We'd be interested in starting an email dialogue with you because this is a problem, and we would like to get your feedback on how we can improve how LI-RADS treats this sort of problem. This sort of.
Sana, which institution you're from? Egypt. Which institution are you from in Egypt?
I was in Venezuela University, but I resigned.
Why you're laughing? That's a great place. We have a question from Dr. Pradnya Mahitar from India, I think. Pradnya?
Hello. Hi, Dr. Kielar. It was excellent cases. It's not really a question. It was just a comment on the first question where we're trying to figure out if things are iso-intense on portovenous phase imaging or they are washout. And I just had a thought, like the way we measure adrenal, can we measure inside the lesion to see if it's iso-intense or a washout? Is that something people do, like put a ROI to in comparison with the liver and kind of say, oh, okay, probably this is not a washout, this is iso-intense to liver?
I know that I can trust that on CT. I don't typically do that with MRI because you kind of need to check everything else to see how it's changing as well. Claude, do you do ROIs like that?
You know, it's a very interesting question, and I sometimes do, but it's very tricky, as Ania said. We tried to do a research study actually on this topic, where we tried to quantify the de-enhancement of a lesion and see if we could come up with an objective definition of washout. And one of the challenges is that the liver itself is heterogeneous. So when you place a region of interest, so the lesion is heterogeneous and the liver is heterogeneous. So depending on exactly where you place the region of interest within a lesion, and depending on where you place a region of interest in the liver, so remember, this is the same lesion, the same liver, so there should be only one answer, but depending on where you place those ROIs, you will get a different answer. So the same lesion in the same liver could be looking hypointense or hyperintense or isointense. It's a very difficult question. And it would require us to have a 2-hour scientific discussion and maybe bring in visual experts, experts on human vision, et cetera, et cetera. It's a very interesting question. Bottom line is there is no simple answer. Now, that's my answer, but Professor Cherniak, maybe you have a simple answer.
Actually, if I could cut in, it's Don Mitchell. My approach, I agree exactly with what you said about the hazards of a simple ROI measurement because you're not accounting for heterogeneity. So my personal approach that I teach to people is to make aggressive use of windowing. Window as narrow as possible. Keep titrating it down till you're almost black and white and use your visual impression. Because I think your own eyes, when doing that, can more take into account heterogeneity than a simple ROI measurement. There probably are more sophisticated measuring tools that could account for it, but in the absence of that, I would trust your own eyes with aggressive windowing. And there are going to be times you're just not sure. And if you're not sure, by definition, you can't call it washout.
That's a great tip.
That's great, Dr. Mitchell. Thanks for also contributing to answering this question. I think the great minds think alike. So we have Roy Furtick. He has also something that is related to what we talked about. Roy, do you want to talk?
Oh, hi, yes. An interesting dovetail. Roy Furtick from Pennsylvania.
Roy, you are from Pennsylvania?
Yeah, St. Luke's system.
Oh, great.
thought that was kind of interesting because once in a while I will get a case where there's such background heterogeneity for especially advanced cirrhosis, areas of regeneration. You're trying to get a sense of what is the appropriate representation for washout. You can pick one area, obviously it could be somewhat similar. Another area might perceive to be washout, making it more and more difficult on those cases. And just wondering how people approach that.
Roy, this is Claude. I actually will have to defer to Don's earlier answer. I think his answer was perfect. It's not. It's sometimes you just don't know. You do your best, but if you're not sure, at the end of the day, if you're just not sure, just say there's not. I can't call it definite washout, and so you may be left with an observation that in your heart of hearts you think is an HCC, but you're just not sure, and you're going to call it a LI-RADS 4. And you could potentially in your report say, look, this is a LI-RADS 4 by strict interpretation, but it has so many suspicious features that I really, that I'd recommend, multidisciplinary discussion. I really think this is an HCC, but it just doesn't quite meet the LI-RADS 5 criteria. And that will happen sometimes. LI-RADS 5 does not have perfect sensitivity, and there will be HCCs that you cannot call a LI-RADS 5 using the current version of LI-RADS.
And that's one of the important about having MCCs or MDDs, whatever you call them in the US. But, the radiologist can take these interpretations and really discuss what we really think, despite what the number might say.
Okay.
Yeah, it seems there's a very large focus on that one criteria of the 10 to 11 in the boxes showed. Obviously, makes it a little more, a lot more leverage on that particular point. And obviously, sometimes you have to take it with a grain of salt and obviously work that into your report.
Perfect. So that's the last question. I know that we can spend the whole day just enjoying this conversation, but unfortunately there is so much time that we can just devote for this. So Dr. Khatri, Gaurav Khatri from UT Southwestern.
Hi, Khaled. Thank you so much. Thank you, everybody. Great talk, Ania.
Thanks for joining.
Yeah. Claude, my question is, you mentioned earlier about the non-categorizable category of lesions in the sort of non-treatment setting, and I agreed with your comments there. The question is, are you more liberal to use that category in the post-treatment setting? If you don't have an arterial phase after a TACE or after SBRT, or any other kind of treatment, local regional treatment, then what do you do?
Hey, by the way, hello. I think that's that's a good point. I think that the concept is the same. The overall concept is that we use non-categorizable for diagnostic imaging and non-evaluable for treatment response imaging. When due to image degradation or image omission, you simply are not sure, not just not sure, you can't even decide whether something is more likely malignant or more likely benign. You can't begin to decide whether something is more likely to be viable or more likely to be non-viable. So yes, I agree in the treatment response setting, if you don't have an arterial phase, yes, you sometimes literally will be in a situation where this could be viable, this could be completely necrotic and non-viable, and I can't possibly make that distinction without the arterial phase. So that I agree with you. If Michelle is still on the phone, I'm curious what she thinks.
I'm still here. I missed the first part of the question. Sorry. Was it about not having an arterial phase?
Yeah, for treatment response, if there's no arterial phase for whatever reason, or the arterial phase is just so awful you can't interpret it, would that lead you more often than not to call it non-evaluable, or how do you deal with that?
Yeah, pretty much non-evaluable is what I say. If you can't, because the treatment response algorithm is largely based on arterial enhancement. There is something in there that you can have washout, but again, if you don't have that arterial phase to show that it was arterially enhancing, possibly, and then that there is truly washout, I think it's really hard to evaluate the lesion. So that would be more like you can't really characterize what the treatment response was and if there's viable tissue.
And hey, Michelle, can I ask a question with that? It's Ania.
Richard.
Oh, Richard's here too. I guess the one question
Yeah.
If somebody had an observation or a lesion that was biopsy proven HCC, but it never arterial enhanced in the first place, in that case, would you be more comfortable interpreting the follow-up imaging if you didn't have arterial phase because it was degraded?
I mean, I think if the appearance of what you're thinking is viable tumor is identical to that or similar to what was on the pre-treatment image in that portal venous or delayed phase, then I think I would be more comfortable saying that there's viable tumor there.
Dr. Do also has something to say.
Yes.
Yes, go ahead, sir.
So the strict definition of viable disease after treatment, the LRTR viable category, does not require arterial phase, right? So even if you have a perfect arterial phase, there's no arterial phase, and there's clearly washout that's nodular or mass-like along the margin of the treated tumor, you're allowed to call that LRTR viable. So in that setting, not having a perfect arterial phase still allows you, by the definition that we have given, to use LRTR viable. Now, if you look at the definition carefully, we're saying it's probably or definitely viable disease. We're not saying that it is 100% specificity. Similar to LR5 is aiming for 100% specificity for diagnostic. For treatment response, we're aiming for high specificity. And in the literature that's been published, there's a few cases where washout alone is specific to viable disease on explant pathology. So there's a precedent for doing that. So we didn't come up with that definition in a vacuum. So I think, strictly speaking, you are allowed to call LRTR viable based on washout alone.
Thanks, Richard.
And if I could also comment, John Mitchell,
yes, Dr.
if I'm sure it's a lesion based on previous identification, and I'm sure there's internal enhancement, it seems like it's highly likely that there is some viable tumor, or at least some not completely necrotic tumor. So, tell me if anyone disagrees with that statement.
Okay, so with that, I would conclude our session today. That was great. I understand that many of us have questions, answers, comments, and those are all very interesting, and those are all even more valuable than anything else. But we would conclude our session by now because we're out of time. I would like to thank all of you. I would like to thank in particular Dr. Ania Kielar for the great and informative lectures and nice cases. I'd like to thank everyone who has participated in the conversation or in listening to the webinar. And I would like to just tell you that we have a great lineup of speakers coming up. So next week we have Dr. Amit Singhal, and he's going to talk. He's a hepatologist, a very nice colleague collaborating with LI-RADS. And he was crucial for integrating LI-RADS into AS-LOD. And he's going to give the clinical perspective for LI-RADS. Is there a clinical need for LI-RADS? So I would actually invite all of you to attend. It is very important to listen to the other side and listen to their needs and what their perspective and what they wanted to see from us. Tuesday, we have Dr. Don Mitchell from Thomas Jefferson, and he's been a great colleague and educator for body MR in general. This is the author who I've been learning MR from when I started my training back there in 20 years ago. And then we have Dr. Avinash from MGH, and he's going to talk about technical recommendations. He is, I think, the chair for the technical recommendation or technique related recommendations for LI-RADS. Thursday we have I think Aya Kamaya is coming first on May 7th. On Thursday, she's going to talk about surveillance of HCC by ultrasound, which is a very important topic too. And David Fitzer is going to talk about hot topic, which is contrast enhanced ultrasound of the liver. And then Monday 11th, Mustafa Bashir is going to talk about imaging of liver iron deposition and steatosis, which is also a very hot and important topic. Not only that, we have a great lineup of speakers coming up, like very nice topics, very important topics, abbreviated MR protocols, and then MR technique related pitfalls, and then we have lexicon, and we have also structured reporting. There is a talk from a surgeon, liver transplant, was very famous and well established in from Pittsburgh, is going to talk about the perspective also of the surgeon perspective for liver transplantation. We're having a talk of imaging for liver transplantation, and we have a talk about pediatric liver tumors. We have a talk about cholangiocarcinoma. A lot of talks are coming up, and we're all enjoying and learning and exchanging knowledge. And with that, I would like to